going to do as a group is proceed with these presentations and kind of work through this booklet and hopefully make it a little bit personal instead of just giving you the raw material, which you could read if you get this manual, you could sit down and read it. But we want to do a little bit more personal thing than just go down through page by page. So drop down to the next page, Jim, please. There we go. Okay. So as Jim said, hearing the words "you have prostate cancer" for a lot of folks is just like being shot through the heart, particularly when they hear the word cancer, whether it's prostate or some other kind of cancer. That's just a word that drives fear and terror into people. And so actually there's a movement afoot to try to come up with something other than prostate cancer, to avoid using the word cancer. And we may have a session on that later on, just because of the kind of emotions and thoughts and so forth that you have when you hear the word cancer, whether it's cancer that you have or somebody else in your family. Whenever you hear somebody has cancer, it's like, oh my gosh, what a terrible thing. And so, this is the #1 cancer for men. This is the leading cause of cancer of all the cancers for men. And it's the second leading cause of death from cancer for men. But so this is something that, it's not just you, it's an awful lot of men out there are going to experience prostate cancer. And, I've heard some people say, if you live long enough as a man, you'll have prostate cancer. And that's probably pretty close to true. There are a few people that maybe lived to 100 and never got cancer, but in today's world, it's probably a very small percentage. So the key I've got highlighted here on this first page is that diagnosis and treatment advances happen often, frequently, and are happening all the time. And so having as much information as possible is going to help you as you go through your prostate cancer journey. And in fact, I was diagnosed in 2017, and in the last 6 or 7 years, there have been new test techniques developed. There have been new treatment techniques developed. There have been new learnings about prostate cancer developed through research and so forth. So, your objective is to hang in there as long as possible because things are going to get better. And it's also important to know that even though almost all men are going to get prostate cancer, not all men have the same cancer or react to the same cancer in the same way. Everybody's body is different. And just like one medication works for this person and it doesn't work for a different person with the same illness, cancer is the same way. It doesn't affect all men in the same way. And that's the good news about it is there are so many different aspects to it that you need to really know what's going on with cancer and as much as you can about prostate cancer, because just talking to your buddy or to your brother or to your father or a friend, reading a book, it may not apply to you, or not all of what you hear may apply to you. You may have a completely different experience. So it's important that each of us take the responsibility to educate ourselves and advocate for ourselves. Jim, if you'll go to the next page. Okay, so we already talked about a little bit of this. There's an interesting one on here, and this is one that's kind of bothered me for a long time, is when the doctors and the people who know what's going on with prostate cancer talk about it, they mention what the survival rate is. And of course, we're all interested in that, and we all want it to be 100%. But they talk about it in terms of the 5-year survival rate. And if you can read it, it says here the 5-year survival rate for all prostate cancer diagnoses is 97%. That means that only 3% of all men who got prostate cancer will die within the first 5 years of learning about their cancer and, if necessary, getting treatment for their cancer. So I always thought, well, why do we only look at 5 years? I hope to last a lot longer than 5 years. And we have a guy in our group that first learned about his cancer when he was 48. And we've had guys in their 50s and so forth. And I think, boy, if they only have to think about their 5-year survival rate, that's not very encouraging to them. You know, if you're 75 when you get diagnosed, well, 5 years is pretty good. You got another 5 years to add on. But that's the measure they use. I was reading an article today that started talking about the 15-year survival rate. And the 15-year survival rate is increasing all the time. They didn't quote a number for it, but they do track that. And there was a very large study, and they had a number in that particular study for a couple thousand guys who had prostate cancer. But I think it's good that they're starting to expand out the tracking around survival rate for cancer beyond the 5-year point. So let's talk a little bit about what are the risk factors in prostate cancer. And there's a diagram here that says, this little diagram with the guy in the middle, and there's 6 different things that they list as risk factors. Some of these we can do something about, some of them we can do nothing about. For example, it says race and age are risk factors. That is, the older you are, the more likely you are to get prostate cancer. Depending on what race you are, Black men, for example, have about twice the risk of getting prostate cancer than Caucasian men. So that's one of the things that, okay, there's nothing you can do about that other than be aware of it. And so what do you do with that information? Well, it means that if you happen to fall into one of those categories or both of those categories, that you're getting older and maybe you're in your 70s or your mid 70s or something like that, or if you're a Black man, then you want to do as much education as you can and educate yourself so you know what kinds of things you have available to you for treatment and prevention and so forth. Some of these things we can do something about. For example, it talks about the environmental factors of diet and some environmental things. You know, what are you exposed to? Chemicals, for example. So if you're working in an area where you're exposed to chemicals in a factory, or your job is painting, for example, or something like that, where you're exposed to chemicals, well, that can increase your risk of getting prostate cancer. So you can take protective measures maybe to prevent your exposure to those things. There's also the diet. You know, the diet affects your overall health as well as your ability to minimize the effects of cancer, or maybe even prevent cancer from occurring. And that includes, you know, the things you eat, the the medications that you take or the vitamins and minerals that you take. There's a lot there. It may be your that goes along with your overall health. And so the better you can maintain your health, the less risk you're going to have. One of the things you can't do anything about, of course, is your family history. And so if there are men in your family, whether that's a father or a brother or an uncle that has had prostate cancer, then that indicates that there's some possibility you might get it just because of your family history. That's somewhat related to the genetic component. So again, there's nothing you can really do about that other than be aware of that and maybe talk to them about what they experienced and how can that relate to you. So if you've had prostate cancer in your family, then you may be as much as twice as likely to get prostate cancer as someone that's never had any cancer occur in their family. Jim, can you slide up a little bit? I don't know if there's anything else on this page, really. Jim, are you there? Go to the next page, please. Now, one of the things we've talked about today, as a matter of fact, is another thing that really affects your risk of prostate cancer is what kind of health care you have available to you. And it's not just what's available, but in a lot of cases, it's what you can afford, because insurance has a big impact on what kind of treatment you can get in terms of what you can afford to pay for. So sometimes, for example, an MRI might be very helpful to the doctors in trying to figure out what kind of cancer you have or how active it is, or is it changing? But your insurance may not cover that, or they may cover only a small portion of an MRI. And then you would have to, if you wanted to get one, you would have to pay for that out of pocket. And so there's a lot of issues that come to play with what kind of insurance you have, what kind of health care you can afford. And now, for many people, insurance controls what can happen. We had a situation in my family recently where we wanted to go to the doctor and have some tests done. And the doctor's office said, well, insurance won't pay for that, so you can't have those tests. And I said, no, I think you've got something wrong here. Whether insurance pays for it or not is irrelevant. If I want to get those tests and you can provide those tests, then I'll pay for them. And they said, well, if Medicare won't pay for it. I said, well, I don't care whether Medicare will pay, I'll pay. So even the providers come across as, if Medicare or your insurance won't pay, you can't get that treatment. They wouldn't make an appointment for someone to see the doctor because Medicare wouldn't pay for it. So it really shows how controlling the insurance system is. Another thing that they've learned is that veterans have a much increased cancer risk over people who have never served. So the numbers they put in here are 1 in 8 men will be diagnosed with prostate cancer in their lifetime. Okay, so that's about 12–14%. But for veterans, the rate is 1 in 5, or about 20% of all veterans will be diagnosed with prostate cancer. Because of that, the Department of Defense sponsors a significant amount of research into new kinds of treatments and testing and runs studies looking for new and creative ways to either prevent cancer or treat cancer or discover cancer. And I have participated in that program in the past. Ethan, who's a member of the group, also has participated in that. And they basically allocate defense funds to go to researchers to conduct research on specifically on prostate cancer, because it's such a big issue in the military, with them either losing veterans through, even active service people through death or through treatment, and they're out, they're not able to serve. And of course, to help the veterans who are getting their health care through the Veterans Administration, the VA system. So it's another risk area. We know that some of the things that they're exposed to, the chemicals that they're exposed to, will have an impact on their risk for getting cancer. I have a friend who was a veteran, served in Vietnam, and he actually got prostate cancer. And of course, there's hardly ever a causal effect that you can actually say for sure, well, that's what caused his prostate cancer. But that was certainly at least a contributing factor to that. So let's look at the next page, Jim. Okay, so I'm going to talk a little bit about how did you find out that you had prostate cancer? So the PSA test is the key benchmark for determining whether you may be at risk for prostate cancer. And PSA, as I'm sure most of you guys know, stands for prostate specific antigen. And so every male is generating PSA in their body. And when you get to a certain age, if you've been going to your family doctor, hopefully that family doctor is recommending to you to begin getting PSA tests. And it's a blood draw. They measure the PSA in your blood and report a number back. And it's based on the number of the amount of PSA per volume of blood that they test. And so generally when you're somewhere in your 40s or 50 for sure, they recommend that every male at least get one PSA test per year. And I've talked to numerous people, including my 4 other brothers, to make sure that they're getting their PSA test. And I had a couple of them say, well, what's PSA? And I explained it to them, and I said, well, didn't your doctor talk to you about this? And they said, oh no, my doctor never said anything about getting the PSA test. So again, you can't depend on your doctor, although we hope that the doctors would all be treating you well and saying, hey, you need to be getting this test because you're at a certain age where it's going to become a large risk factor for you. So you start getting the test, and what that does is provide a baseline for where your PSA is. And then the community, the doctors have and researchers have established some threshold of at what point does this PSA number start to be a concern. And sometimes that's all that they do, is they just track the number, and as the number goes up, they start watching it. And when it gets to 3, 4, 5, 6, depending on the doctor or the practice that you're going to, they'll say, well, it's reached a point where we need to do some additional testing. And so what they'll do then is move on to the next phase. Now, if you're going for a regular physical, your doctor likely will be doing, again, when you get to a certain age, the doctor will likely be doing a digital rectal exam, DRE. And that's exactly what it says. That's the digital is the doctor's finger, and the rectal is where the finger is placed. And the examination is the doctor reaching in and actually putting his finger on your prostate and moving it around to try to see if there are any lumps or hard or very, very soft areas where it doesn't feel the same. And if that's the case, then the doctor will say, oh, we better do some additional testing because you might have a problem here. So it can be through either one of those tests or both of those tests that the doctor may become aware that there may be a concern for prostate cancer. Now, the important thing here is that there is no magic number. As I said, there could be 3, it could be 4, it could be 5. And even if you look at a number, what's likely more important is what was it the last time you got a test? What is it now? And what is it the next time you get a test? And so you want to look at not only what the number is, but how it's changing over time. Because number one, your PSA will go up just because you're getting older. Whether you have prostate cancer or not, the PSA number will rise over time. And I've been told by a couple different doctors that it can go up 1 or 1.5 each year. And that wouldn't necessarily be considered abnormal. But you know, it's usually when I first started getting tested, that was back, I don't know, 30 years ago. Mine was down in the low 2s, around 2. And over the years, it moved up a little bit at a time, a little bit at a time. And we just kept watching it. You know, I'd get my test every year or so, and no big deal. In my case, when the number got to 4, my doctor said, I think I better send you to a urologist. He had been conducting the DREs from time to time. It's always a very pleasant experience, and never found any problem there. So the PSA in my case was the key indicator. And when it got to 4, then he said, you need to go see a urologist and talk to somebody that's a specialist. It's not my area of expertise, so need to have you go and talk to somebody else. Another thing that's important around the PSA test. So if your doctor is having you take regular annual PSA tests, you want to ask the doctor, where does he or she send your test for analysis? Because if you take the same sample of blood and send it to 3 different labs, you might get 3 different numbers because there's some amount of variation in the test method, and in the tester. So it's important to make sure you're using the same laboratory all the time at the same location of that laboratory. If for example, the test company LabCorp, for example, is one of the test companies that does this. They may have 2 or 3 offices or tests or laboratories around the Cincinnati area. And one time the doctor may send it to Sharonville, and the next time they send it down to Covington, And the next time it goes over to Mason, to the various labs, well, that means you're getting it from 3 different individuals, 3 different labs. They may get different results, and you get a lot of potentially erroneous data, and can cause problems. So nobody's put any questions into the chat, but if you have questions or comments, or if you want to share, an experience that you've had as I'm going through this, please speak up, raise your hand, jump in, do whatever, so that, we can all benefit from each other's experience. So you're going to end up going probably to a urologist, and you'll take your medical record along with you. And the urologist is going to look at it and say, I think we need to do something more to find out if this PSA increase or this PSA level indicates that you have, there's a potential for prostate cancer, and we need to do some additional testing to determine if you have it, and what's really the status of your cancer. So likely the first thing that they'll say is, we need to do a biopsy. And as you guys all know, if you've had one, likely you have, because you're all got in either the treatment process or somewhere along the path. That's where they take some needles and stick into your prostate and draw a small sample from your prostate. And then they send that to a laboratory. They look at it under a microscope to look at the actual tissue to see if there's any abnormalities in it. Does it look like it has cancer? And this is another one of those things, like the PSA test, where if you have to have another biopsy, you want to make sure that they send it to the same place. And ideally, the same expert reads that biopsy, because this is a very subjective measure. When they look at this thing under the microscope, it's pretty subjective. And I think later on we'll have some samples that we'll be able to show you, so you can get an idea of what these tissue samples look like under the microscope. And so it's kind of difficult to read it. So basically, that's what they do, is they go into your prostate and take some tissue out and send it off, and that comes back with a reading. Now, there's a couple important things before you agree to that prostate biopsy that you ought to know. The first is, how are they going to do the biopsy? Obviously, the prostate is inside your body, so they have to go inside your body with these needles and extract the sample. And this article mentions 3 different methods or techniques that they use to actually get inside your body and take those samples. There's the transrectal method, the transperineal method, and the transurethral method. Now, today, when we had a meeting with 4 or 5 of us, none of us had heard of the transurethral method, and I didn't research it to find out what that is, but that's a new term to me. I've never heard that term before. So that's one of these things that is out there that even as long as we have been doing it, we've never heard it.
Hey, Ed.
Go ahead. Somebody comment?
Yeah, Ed, this is Preston. I did a little bit of research on that just because I was curious to see what the advantages and disadvantages were. And the only thing definitive that I could find was one study where they used transurethral after they'd used transrectal, just to see if it would pick up cancers that were missed by the transrectal. And the conclusion was that doing a transurethral after doing a transrectal added no value to the diagnosis. And again, I only researched this for 15 or 20 minutes, so it's not definitive. But my thinking is right now that the transurethral is either so new that they don't have any data on it, or it's not significantly better than the transperineal or the transrectal. There was available differences between transrectal and transperineal, and the major difference was the infection rate. The infection rate for transperineal is much lower. It's in the range, if I remember correctly, 3% for transperineal, and it's 10 to 20% for transrectal, as you might imagine, going through the rectum is not as clean as going through the skin. And also, of course, they can swab the skin before they begin the procedure to make it clean. So anyway, that's what I found out about transurethral and the other two methods of doing a biopsy.
Great. Thanks, Preston. I appreciate that. So this is an example of what I was talking about earlier, where when I first got my biopsy, there was, as far as I know at that time, there was only one method, and that was transrectal. And as Preston mentioned, transrectal means they go in through your rectum and access your prostate that way. And because of that, you're going in through the rectum, and even though you're trying to cleanse your rectum and colon out as well as possible, there's still a significant chance that there's going to be some feces there, and that's the risk for the infection. So it's very common, and in fact, I actually had to take some antibiotics before the test, before the biopsy was done, to kind of make preventative in case there was any infection. But at the time I had mine, I had never heard of this transperineal. And I think that's only come about in the last few years. And for those of you that don't know what that means, the perineum is the skin between the rectum and your scrotum. And so it's the tween skin, right? And they're just going through clean skin there into your body and accessing the prostate that way. So it's less chance of infection. In addition, it may give them, depending on where your lesion is, it may give them better access to the lesion if they're trying to find a particular spot on your prostate. So Brian has put a note over here in the chat box, if anybody's monitoring it, and pointing out that the other thing that you want to do before you agree to this biopsy, in addition to saying which method are you going to use, and right now we would say the transperineal, if that's possible, is probably the best method to use. He's talking about, with regard to the PSA, it's not just the number, but it's what's the time frame between it going from 2 to 4 or 1 to 3, or that kind of thing, the doubling time. And if you've gotten additional information on your PSA test for not just the number for the regular PSA, but for percent free PSA, that's a measure of kind of how aggressive the cancer may be. Those are important numbers to know as well. And the doctor may order, your urologist, when you go to him or her, may order an additional PSA test and ask for those kind of things. The other thing that you should ask for is an MRI. And I know, for example, that the urology group, who is one of the big organizations in town that treat prostate cancer, their kind of standard is to use ultrasound. And we're going to talk about the imaging in a minute. But MRI is another method where they can take a look at your prostate and look for any particular concerning images. And so they want to find, is there actually a spot on your prostate that looks different than all the rest of it? And if that's the case, that's the likely place where the cancer might be. That's the lesion or the location of concentration of these cancer cells. And if they can see that, then they can use the MRI picture to direct the needles where they're going to take the samples. Because when I took my biopsy, and I actually had 2 of them done, they took 12 samples from my prostate. And I think that's kind of a normal number. I've heard some people say they took 8 or something, but they took 12 samples. And they take those 12 samples in a random pattern, kind of 2 out of the top, 2 out of the bottom, 2 out of the right and left sides, and 2 out of each of the diagonals. Just think of a compass, and they kind of go around the compass and try to take some samples. So I call that the poke and hope method. They're just sticking randomly into your prostate and hoping that they find where the cancer is. But if they can do an MRI or an ultrasound, sometimes the problem may show up on an ultrasound. But if they can guide those needles by looking at the ultrasound or the MRI and knowing exactly where to look, because they've got some difference in that particular area, they have a much better chance of locating where the cancer might be and getting a better indication of how much cancer you have and how advanced it is. So MRI is not the accepted technology at this point across the standard of care, but it is very helpful in your getting your biopsy and getting good results from it. Jim, I think I'd like to go to the video at this point and put that up and play it. We're going to have about 15 minutes of it, and that'll set the tone for the next section.
Okay.
Anybody have questions or comments at this point before we turn that thing on?
I did post up something about that transurethra biopsy, and it said something about that it was used primarily if the PSA continues to rise, but there's a continued negative transrectal or biopsy. So basically, if the other ones fail, then you got something to look forward to, I guess.
Okay, great. Thanks, Brian and Jim for putting that up there. Okay, let's take it away.
All right.
Creating content just like this. Now back to this video on random needle biopsies versus targeted biopsies. So the differences between a random needle biopsy versus an MRI targeted biopsy. So when I think about a random needle biopsy, I've heard you talk about kind of the clock pattern. It's 12 to 14 needles in a prostate and they're going around, or even a grid pattern. My thought when I, was first learning about it is, wouldn't you miss the cancer in between? Why are we not using imaging in today's day and age? And, it's interesting, even though we have MRIs, we're still seeing a rampant usage of random needle biopsies across the US and all over the world now that we have this international audience. So can you explain kind of the modalities of how MRI targeted biopsies are done? There's, different types, and also what are the benefits of it versus a random needle biopsy?
Getting an MRI when your PSA is above some threshold in this study, the PSA greater than 3. As a first step, rather than simply jumping into the random needle biopsy that you mentioned, is a new policy that is starting to pick up momentum around the world because it's a better approach, but it has not become universally accepted. So there's still 1 million men every year in the United States that are just getting a random biopsy because that's the way it's always been done. Like you say, the logic behind doing an imaging study and targeting an abnormality in the gland makes a whole lot more sense because they can use fewer needle sticks just to go after the little shadow rather than just sticking needles everywhere. And it's been clearly shown that you're more likely to find the type of cancer that needs treatment when you target a spot rather than just randomly stick needles around. The question that comes up, of course, is if it is better to do an MRI-directed biopsy, is it even better to do both? And we'll go into that issue more as this article addresses that question. But I think you're right in highlighting that the first steps that men take after they discover their PSA is above the normal range can really change the course of their future if they just jump into a random biopsy as opposed to doing an MRI first. And many men that do the MRI first who don't have any spots or suspicious areas won't need any biopsy according to the results of this recent study.
So one of the things I would like to clarify, I was at a conference and we were talking to some prostate cancer patients and they heard this big study that Dr. Klotz was talking about where Gleason 6 does not metastasize. And they said, well, wait a minute. What if, doesn't Gleason 6, doesn't that cancer turn into a more aggressive cancer? And so we had to explain to them, no, Gleason 6 is completely separate. If you do have a high PSA and they do target another lesion and it's any other type of Gleason grade that is higher than 6, that's not the same tumor. And so one of the things that I realized is that patients need to understand that not finding that Gleason 6 doesn't mean that those particular tumors that are Gleason 6 that are in the prostate are going to turn into something else. And can you explain that better? You know, this is a patient, but can you give me the physician, perspective?
I think you explained it very well. And the idea that you can have different types of cancer from one organ, I think is nicely illustrated in the skin cancer world, where we have a more sensible way to name things. So we call the harmless skin cancers like basal cells and squamous cells, and we call the more consequential cancers melanomas. Totally different name, totally different disease. But they both come from the skin. In the prostate world, sadly, we use a numbering system that gives an idea that there's sort of a continuum. Basal cells and squamous cells do not turn into melanomas. They never turn into melanomas. Low-grade prostate cancers don't turn into high-grade cancers. But because you can have more than one skin cancer in your lifetime, you can have more than one prostate cancer in your lifetime as well.
Because if I'm thinking I'm getting a random needle biopsy or a targeted biopsy, either way, if that Gleason 6 is being missed, I want to make sure it doesn't turn into something. Because everybody's going, shouldn't you know ahead of time? We're always pushing screening. So if we're pushing screening, shouldn't we know everything? And that's kind of the conundrum when it comes to the world of prostate cancer. You just think, well, if I know everything, I'm going to have more power and I'm going to know my steps. And to a certain extent, that's true. But because the medical system is just ready to treat, you can also suffer significant side effects. So can you talk about the results of this study and what you think is the most important point to a patient who's reading it?
So in the study, they did a really nice job of evaluating the relative benefit of doing a targeted biopsy and or a random biopsy. And what they found, the bottom line of what they found, was that the addition of a random biopsy to an MRI targeted biopsy doubles the incidence of finding 3+3, which is not unexpected, but they quantified it. And that is the type of risk that you take when you do a random biopsy. You're twice as likely to find 3+3. The other thing they found was that by skipping the random biopsy, there was a 5% chance that you could miss something that you might want to treat. The 5% that were missed were small and low grade. They were 3+4s in all cases. So the MRI targeted biopsies were missing very little significant cancer, but they did miss some very small intermediate grade cancers, and it was at about 5% of the patients. So this is the trade-off. What is worse, the dangers of being unnecessarily told you have cancer and possibly leading to unnecessary surgery and radiation because people get scared, or delaying the diagnosis of a small intermediate risk cancer for perhaps a year because to mitigate the risks of this, of course, we advise everyone who has an MRI that doesn't show anything that they repeat the MRI a year later. And if there was a small intermediate grade cancer that was missed on the initial MRI, if it is growing, it should be picked up in a timely fashion while it's still curable. I think we have to mate the policy of foregoing biopsy altogether in men with normal MRIs, so PSA is up a little bit, MRI is normal, no biopsy, with the injunction to get another MRI a year later in case you're in that 5% category where there's something too small to be detected on the initial MRI.
So being a medical oncologist, you're not a urologist doing biopsies, random needle biopsies. You do targeted biopsies with color Doppler in your practice, I know that. But, in your perfect world as a medical oncologist across the planet, would you say we should not do like random needle biopsies at all? Or are there particular cases where you say, no, this is where this should be used, but MRI should be first?
I don't see any scenarios now where we need a random needle biopsy any longer. We would query ourselves because some men have a lot of prostatitis, they run really high PSAs, and their MRIs are clear, and you kind of get nervous. Is there something we could be missing? That fear has been assuaged to a large degree now with these new PSMA PET scans. Rather than going in and just randomly harpooning the prostate, what we'll do is get a PET scan and make sure that there's no cancer. Modern PSMA PET scans are over 90% accurate for picking up cancer either in or outside the prostate gland. So I don't see a role for random biopsy anymore in 2020, now 2024.
So a common question I get now, because we're talking about PSMA PET scans, is why don't we do PSMAs first? Why even do MRIs?
Well, there's a little bit of radiation in a PSMA PET scan. The beauty of MRIs, there's no radiation at all. MRIs are far less expensive now. They're doing studies where they don't do any contrast, and they're getting the cost of these scans down to $500. So that makes it far more attractive. A PET scan retailing now for $5,000 to $7,000. So no radiation, less expensive, a lot more experience. PSMA PET scans are new. We've been using prostate MRIs now for 8 or 9 years with greater and greater frequency. But as a backup, it's nice to know that those PSMA PET scans are available to double check things.
And as far as the MRI goes, 10 years ago we were talking about 1.5 Tesla, the magnet that's used in these MRIs versus 3T. Would you say that 3T MRIs are the most common? And if somebody does encounter a 1.5, do they need to go get the 3?
Yes, definitely. I think 3 Tesla MRIs are considered the standard. And even more important than that, the doctors who are reading these MRIs need to be very experienced. PSMA PET scans are fairly straightforward. PET scans have been around for a long time in the interpretation. Prostate MRIs, more challenging. So if you're going to a center that's only doing a few prostate MRIs a month, you probably should have those images overread at a university somewhere to make sure that the interpretation is correct.
So can you talk about the potential risks to a patient when it comes to side effects of treating Gleason 6? There may be, pressure from their doctor saying, well, you have cancer, we've diagnosed you with cancer, so why would you not treat this? And kind of talk about the ins and outs of what they could experience.
In my experience,
Jim, let's
for example,
stop
if
that
people
video
go
here.
have a radical surgery.
Great. We may get back to that later. So a couple of things I just want to emphasize about the video. He talked about when we're talking about watching your PSA test, your PSA results, and using the same lab and so forth. He mentioned a couple other key things, and that is that when they take the blood sample and read your PSA, it can vary. You will get variation just caused by other things. He mentioned prostatitis. And so that's kind of like an infection or an inflammation in the prostate. And that can come from a lot of different sources. For example, you may have an infection in some other part of your body, a cold, or you recently had the flu, or now you recently had COVID, but you're over it. But some of that infection may still exist, and it may be in your prostate, and it'll affect your PSA. How many days ago did you have sex? It will affect your PSA. So there are some studies out there that talk about what kind of medications you're on or what kind of supplements you're taking that might affect your PSA. So all of those things could come into play when you get your PSA. So that's why it's important to get regular PSAs and be tracking them. And if you see some increase, like it goes from a 4 to a 6 from one test to the next, that could be, something that can be explained by some external factor and not necessarily related to the prostate cancer. Go ahead, Brian.
Just wanted to say also that your PSA can drop unexpectedly. For instance, if you're on finasteride to help with urinary issues, that drug artificially cuts your PSA in half. So if you think you've got a 3.0 PSA due to the finasteride, it's actually a 6. And that can start leading you in the wrong direction if you're taking that medication for urinary issues or for baldness. It's used for baldness also. Proscar, very similar drug. So something is going to artificially lower your PSA and lead you in the wrong direction, thinking you're okay when you're really not.
Great. Thanks, Brian. That's exactly what we're talking about. So again, you don't want to go nuts when you get your PSA back and it's a 5, because the doctor said, well, if it's over 4, you got prostate cancer. Well, maybe you do, maybe you don't. So Brian had pointed out, what was it last time? What was it the time before? Those kind of things. So yeah, go ahead, Bruce.
Could you please send the link around to the video we just saw?
Sure.
Yeah,
Okay.
yes, it's actually in the chat. No, it's not in the chat. But maybe Jim can post it in the chat there.
Thank you.
So you can watch that.
Thank
if you
you.
want to go back and look at it. Thanks, Bruce. Okay.
Ed, it looks like Preston also has some stuff
Okay.
in the chat too.
All right, great. Yeah. So yeah, thank you, Preston. That's a good reminder. I was gonna cover that. So when they do the PSA, when they do the biopsy, they're going to take these cores that they get, however many it is. In my case, it was 12. Brian put up there that he had some that were 20. And they're going to look at each sample, and they're going to do an analysis to say, of the 12, how many of those 12 showed some amount of cancer? Some of the samples will have no cancer. Some may have, some of those 12 samples may have some cancer. And then the next point they'll do is say, well, what is the volume of the cancer compared to the total volume of the sample? So it may be 5%, it may be 20%, it may be 50% of that particular sample was cancer cells. And then they use that information to give an indication of how much cancer you have. And that's the time when you may start to get concerned. And we're going to talk about that issue on our next session. But that's the key is once they get the prostate biopsy back, then you'll want to we'll help you understand what that means. Also, Dr. Stoltz pointed out that there was this question about the MRI machine. If you're going to get an MRI, this is another area where the technology has continued to improve. And when I got my MRI, my first MRIs, it was on a 1.5T. And then through this group, I learned that, oh, there's 3T, which ostensibly is twice as good as 1.5. I don't know whether you can make that comparison or not, but it's better than a 1.5, meaning the clarity of the image and the if you will, think of it in terms of pictures, there are more pixels that they're going to be able to use to get a much better image and pick up things that the 1.5 might not have. And so if the doctor is sending you to get a MRI, you want to ask, what kind of MRI machine is it? Is it a 1.5 or a 3? And so I originally went to ProScan, who's the big MRI provider in town. And they had, at that time, 1.5s. And I found out that UC had a 3T. So I now go to UC whenever I get my annual MRI because it's a better machine.
Quick
Yeah,
note
Brian,
there.
go ahead.
ProScan now has a 3T, I think, in their facility in northern Kentucky.
Okay. Okay. Brian?
Yes. I was going to ask you, when you used that 1.5T MRI for your initial MRIs, did they use an endorectal coil?
No,
Okay,
no.
because sometimes that happens these days. You've got some men that have hip implants or hip replacement, which would distort the image that the 3T MRI creates, or if they have some implants in their body, cochlear or heart or whatever implants, those can't be near MRI sometimes.
Yeah.
I've heard that in those cases, they do use a 1.5T MRI, which is low power, as you indicated,
Right.
but with an endorectal coil in order to enhance the image, but still not be impacted by the other anatomical features in the man's body. So,
Okay.
there are still some uses for that old technology.
Yeah. Okay. Good point. Good point. Yeah, I had my first biopsy. I did not get an MRI. They used an ultrasound to do the biopsy, and then when I got my second, when the doctor said, "Hey, it's been a year, let's go back and check that and see if that's really good." Again, that was a poke and hope. So let's get another check. I think that was somewhat at my urging to get another biopsy. And I said, okay, I'd like to get an MRI. And so I got an MRI. And then we get there that day to get the biopsy done. And because I said, I want a fusion biopsy. And that's where they take the MRI image and they combine it with the ultrasound so that they can really target your lesion. And I said, so doc, are we going to do the fusion biopsy? He said, no. And I said, why not? He said, because your MRI didn't show anything. And that has been consistent through all of these years of me getting MRIs. They've never seen a lesion anywhere. There's some indication of a little fuzzy area, but none of the doctors that have ever looked at it have said you've got a lesion. Yeah, Bruce, you got a question or comment?
Something led you to seek another biopsy. And you were actually the driver behind seeking another biopsy. I was wondering what led you to want to get another biopsy.
Yeah, it was because of coming to this group and finding out that getting a guided fusion biopsy was the way to go. My doctor never mentioned it.
Okay. I was wondering if you saw some numbers going in the wrong direction or something.
No, no, it was just I got the first one and I wanted to get another sample.
Okay.
And get a double check to make sure that since it was a poke and hope that there might not be something there they missed.
Thank you.
Okay, next page, Jim. Okay, this one's a little bit more difficult to read, but we've been talking about the MRI, and I just wanted to get a little bit of kind of an overview of these imaging techniques that are out there. And so I mentioned ultrasound. That used to be the way that they looked at the prostate, was through ultrasound. And they use the ultrasound when they're doing the biopsy so that they can see, if you will, where the needles are going in, where the prostate is, make sure they get the needles into the prostate, and that they get them into whatever pattern they're trying to do. As the video indicated, sometimes it's like going around a clock or around a compass. Sometimes they lay out a grid, you know, four vertical lines and three samples out of each line, something like that. So they have different patterns depending on maybe the size of your prostate, as well as the particular policy of that doctor or that office. The MRI scan, we talked about that. That, of course, I've had MRIs on other parts of my body, and that's a relatively new technique that they've been using for 10 or 15, 20 years, I don't know. That they take of other parts of people's body to look inside and get kind of a picture of what your body looks like, what organ they're trying to look at. Whether I've had MRIs of my heart, of my prostate, of my knees, you know, when I was having knee problems. Then there's CT scans, and this is another technique. The CT scan is a radioactive kind of thing. So you're exposed to some radiation when you get the CT scan. And so I've had those of my heart, for example, and the doctor said, well, we've given you 2 CT scans in the last 2 years. We're going to do MRIs for a while because we think we can get a credible image and accomplish the same thing without the radiation issue. So that's another kind of scan that they may do of your prostate. And then they talked about the PET scan, and that's a better quality of CT scan, again, using different kinds of isotopes to project some portions of the thing to light up that they can see. And then it was mentioned in the video right at the end there about the PMSA PET scan. And that's the newest version of the particular isotope or the chemical that they're using to give the better image. So this is another area where there's continuing development and research into new ways to look at the cancer, to see it, to find out what kind of cancer you might have. And these are the things you should be discussing with your doctor when you're talking about getting a scan, either before or after your biopsy, or as a part of your regular monitoring program that you might want to discuss, find out what are the differences between them, what are the risks, what are the advantages. Again, as we mentioned, getting the radiation exposure is one of them, and as opposed to an MRI, which is a magnetic imaging, as opposed to radiation. So, but the key is that this can help in looking at your prostate to see if there's abnormal cells there, in addition to taking the biopsy and actually pulling out the tissue and analyzing it with a microscope. So these are the key things that in the beginning of your journey, before you decide on any kind of treatment, you want to make sure, number one, that do you have prostate cancer, or is your increase in PSA a result of one of these other things that we talked about that can cause it to go up, or is your increase in PSA solely a result of your aging? You're getting older, so the PSA is going up naturally. And they're using these tools, the biopsy, the PSA tests, and the imaging to determine if you have prostate cancer, and how bad, if you will, is your prostate cancer. So that's what I wanted to cover tonight. We're going to move on whenever we have our next session around this topic, and go to the next step in your journey, which would be, okay, now that you've got the basic data of your diagnosis, what are you going to do about it?